I'm Alice Jacobs from Boston, and I'm here at AHA Scientific Sessions in Orlando. And with me is Dr. Kristen Newby from Durham, North Carolina, and Dr. James DeLemos from Dallas, Texas. And we just attended the third late-breaking clinical trial here at Scientific Sessions on ACS and PCI, the continuum of care. We heard some potentially practice-changing trial results, and we would like to share the salient features with you. So the first study was a randomized trial of intravascular ultrasound in patients receiving the newer generation drug-eluting stents using IVUS-guided versus angiographically guided procedure. And the trial had clinical endpoints, which is something that we were really pleased about. I think that we are in search of an evidence base for clinical endpoints to inform our clinical practice guidelines, and showed that in patients who were treated with long lesions with drug-eluting stents using IVUS versus angiography, that there was a benefit in terms of clinical endpoints, driven really by a decrease in repeat revascularization. So take-home messages, Kristen, on this one.
So I think you highlighted a number of the key points. I mean, this was a large study. It seemed reasonably well done. And I think it has the potential to inform practice. I was a little bit surprised at the fairly large number of people who were not treated, I won't say according to the guidelines, but who didn't receive what we would consider standard of care.
So I would agree, because it was of necessity unblinded, and the angiographic guidelines were if you had a residual stenosis of less than 30%, you wouldn't do a high pressure inflation, which is really not standard of care, and one wonders if you just post-dilated both groups if you would have had the same results. So I think more to come on that trial. The second trial, we got the results from the RIVER PCI trial. So the main results were previously presented, and this was a randomized trial of ranolazine, 1,000 milligrams versus placebo in patients post-PCI who had incomplete revascularization. Incomplete revascularization was defined anatomically. And there, in the overall trial, there was no really change in the endpoint, which was ischemia-driven revascularization or ischemia-driven hospitalization. And in the quality of life endpoints, not surprisingly, there was also no difference. James, any take-home messages here?
I'd say it's not all that surprising that a prophylactic ranolazine strategy used here didn't improve outcomes, given that it's really a drug that seems to work best for people with a high burden of angina. And even here you could see some trends towards improved quality of life in subsets with diabetes and with a high angina burden, which kind of supports the way we already use it, is in individuals that have persistent angina on good medical therapy. And I think it supports that, but not in the extension of the indication.
Yeah, so I would agree. I think we didn't know a lot about the incomplete revascularization. We knew it was anatomic. We didn't know if it's intended, unintended, functional, serving viable myocardium. Women, I think an opportunity, ranolazine based on the mechanism and the added chest pain that women have would be another opportunity. So I think more to come on that front. And then we heard an additional analysis from the Pegasus trial, so the TIMI 54 trial, and that was a randomized trial of extended dual antiplatelet therapy with 2 different doses of ticagrelor versus aspirin alone in patients who had a previous myocardial infarction. I think it was 1 to 3 years prior. Right. And that trial, the overall result showed a benefit in decreasing ischemic events at a cost of added bleeding. And what they looked at, interestingly, was the reasons for discontinuation of the drug, which it seemed like a higher than anticipated rate of discontinuation. And the main results, thoughts that you have about what they told us?
Yeah, so I agree. A higher rate of discontinuation than we might expect. It was like around 20%, which is pretty high overall, even in a clinical trial setting, or maybe especially in a clinical trial setting. About a third due to bleeding, about a third due to shortness of breath or dyspnea, and about a third other causes, which are largely unexplained at this point.
So we asked them about, dyspnea. I think you can predict which patients might have bleeding as a reason for discontinuation, but dyspnea seemed, I couldn't really figure out, can we predict the patients who would have dyspnea? It was profound, although it wasn't serious. It came early on. So early on, they discontinued the drug based on dyspnea. And we were wondering whether it was more prominent in women, whether it was related to LV function. I think we were surprised about it because in stable patients, you would think it would be less likely to have ischemia. You would have transient ischemia in the ACS setting, but not necessarily in this setting. So I think we'll learn more about that as well.
And I think it's a little bit artifactual because remember in this study they were initiated in the outpatient setting having not received the drug previously, and so much of the discontinuation was early after they started it. And the question I think will be, how does that translate into the more common clinical scenario where somebody would be initiated post-ACS and continuing when they already would have experienced this. But it was interesting that a full third of the discontinuations were not related to dyspnea or bleeding.
Yeah. So again, real world practical questions if you have this incidence of discontinuation in a clinical trial. In clinical practice, we could expect even a higher rate. So, and then James, you were the discussant on the DAP trial. So the DAP investigators performed a very clever analysis now, and something that we think about all the time, which is balancing the risk of ischemia versus the risk of bleeding in extended dual antiplatelet therapy. So tell us a little bit about that.
Yeah, so what they did was clever. They basically created a series of models and then a final strategy to try to identify variables that uniquely predicted either ischemia or bleeding or not both. And then they created a score to estimate the treatment effect for a net outcome that included ischemia and bleeding. Really what we're trying to do is isolate who should we treat that has a favorable net reduction in ischemic events without a cost of bleeding, or who shouldn't we treat because their bleeding outweighs the ischemia. And using this score that's really quite practical, we think, they were able to stratify that half of the patients in the DAP trial had net benefit associated with the drug, and half of the patients actually had net harm. And I think this is the first real step forward to personalize this approach. Everybody's been talking about the need to personalize it, but the tools have been really weak so far because so many of the variables predict both ischemia and bleeding. And here they have a sort of a take-home tool that gives us at least a first step to try to make these decisions in the outpatient setting when the patient comes back after a year on therapy. So I was quite enthusiastic about the applicability.
Anything to add, Kristen?
No, I completely agree. I thought it was a great analysis and one that we really need for practice. Yeah,
and will be very helpful for us to have and to use this tool. I think it will evolve as the variables will evolve, but it's a great start. So kudos to them. And then finally, you were the discussant on the PROACT 4 trial. So tell us a little bit about that.
Yeah. So PROACT 4 was an interesting trial. It was done in Canada, which has a very structured emergency medicine system and integrated hospital system in their large cities. What they did was ask the question, can we shorten the time to making a decision to admit or release a chest pain patient from the emergency department by checking troponin in the ambulance? So they leveraged, in a very pragmatic way, the system that already exists for emergency cardiac care, for STEMI and for cardiac arrest, and just added, in addition to the electrocardiogram, troponin testing at the point of care in the ambulance, and randomized people to either get that or not. And what they expected or anticipated as a clinically relevant difference and we're looking for is a 60-minute reduction in their time to making a decision, which would be very clinically relevant, particularly in crowded emergency departments. What they found was that the result from the troponin testing was available about 100 minutes earlier when it was done in the ambulance than when it was done in the emergency department, but that did not translate to a substantial shortening of the time in the emergency department. It was still between 8 and 9 hours for both groups and only 20 minutes difference between the two, which to me suggests that there are structural issues or process issues within the emergency department and how that information is used that are going to be the next step for that group in particular, but for all of us to consider in trying to reduce that time to disposition. The other thing they didn't have the advantage of was high sensitivity troponins, which the European community now has the advantage of, which can dramatically shorten decision times just because they only require an hour or two between blood draws to make a decision.
So clearly, real world. I think we are all addressing moving patients in and out of the ED quickly. I just, was not certain how they really could determine or factor in, how busy ED was as a, confounder for how fast you make your disposition, what the staffing was that day, what time of the day it was, and then what was the time from the patient's symptom onset to getting the troponin. So if you're on your way and you have a negative first troponin, is that okay, or do you still need another troponin?
Yeah, so that's a great point, and certainly the first troponin, will need to be repeated at some point. And with the sensitivity of the assays, they were using probably sometime between 3 and 6 hours with the higher sensitivity troponins. Perhaps that could be shortened. And so I think a number of things. A number of things it highlights that need to be addressed, and I think your point about day of the week, time of day, are also very important points to be considered.
So you think there will be next steps?
I think there will be. I think we have to. I think overcrowding in our emergency departments is a huge problem, so we're going to be forced to look for clever ways to shorten that.
So clearly, I think more to come on many of these trials, but very interesting, provocative results, and it's been a good day here at Scientific Sessions AHA, and we thank you for attending.